the team here to welcome you to our home, the Institute. So before we get started, I would like to pay my respects and our respects to the traditional owners of the lands on which we're meeting today, which here in the east of Sydney is the Gadigal of the Eora Nation. We pay our respects to elders past, present and emerging. If anyone's wondering, I do have a couple of Indigenous patients with FMD and SCAD. I don't know if they're here today and they don't need to put their hands up, but you know, it is a disease that FMD and SCAD that cuts across all sectors of our society, and we're not aware that there's any racial or ethnic biases in the disease. So welcome to you if you're present. We've got a fantastic day today, and I welcome Pam Mace and Santhi Ganesh there. Pam's coming to us from Cleveland, Ohio. Santhi's in Ann Arbor, Michigan. Both are really great friends of mine, and they're going to lead off tonight. It's about 7 o'clock for them on a Friday night. So we put them first so they can get on with it. Santhi's got kids she's got to get to bed and stuff, so we'll let her get on with that. But we're going to make full use of them both first before we dive in. I did want to say a few words about SCAD and FMD just to set the stage, because this is the first time we've actually brought SCAD patients and FMD patients together for a combined patient information day. So we've been working, and Santhi and I have been working in Pam for 10, 15 years on both of these conditions. And for those of you with SCAD in the room, you'll know that about half of patients with SCAD have FMD. For those with FMD, you will have heard about SCAD. A couple that were originally diagnosed with FMD may have had SCADs, and SCADs with FMD, FMDs with other arterial dissections that is not SCAD. So while there are some distinctions between SCAD and FMD, at a genetic level, at a molecular level, there are a lot of overlap features between these diseases. And as we all know in the room, both SCAD and FMD are mostly diagnosed in women, mostly in the age range of the late 40s to early 50s. So I know there's some men in the room with FMD and SCAD, and that's great. But just to say, there's a lot of shared features. So we brought the two conditions together today and the patients together today. And I know there's a bunch of people who've got both FMD and SCAD in the room anyway. But for those, I just want to say from the outset, for those of you that have got FMD, the risk of you now having a SCAD is very low. So I don't want to freak out any of the FMD patients that haven't had SCAD, because the risk is really low. And for those with SCAD that don't have FMD, FMD develops really, really slowly. So it's quite unlikely you're going to develop FMD. Okay, so just to set that straight, I don't want to freak anybody out by bringing them together and think, well, I'm going to get that one and, you know, et cetera, et cetera. Okay. But that said, there is a lot of commonality and similarity between the two conditions. Although FMD has this hallmark string of beads, and the FMD patients know what I'm talking about, one of the other features of FMD is arterial dissection. Obviously, that's what a SCAD is an arterial dissection. So Santhi, myself and others do actually think of these diseases somewhat as almost the same condition, FMD and SCAD, just manifesting a little bit differently in different people. And you'll know with atherosclerosis, which we're not going to talk about at all today, but just to mention it quickly, atherosclerosis, plaque build-up in the arteries. As we all know, some people with that plaque build-up stuff will have a stroke, some will have a heart attack, some will lose a leg from peripheral vascular disease, and some might even go on dialysis from kidney failure due to blockage of the kidney arteries. Exact same disease, just manifesting a bit differently in different people. And I think that's how we more and more think about SCAD and FMD. So, but anyway, no need to freak out, because if you haven't had one or the other, it's super unlikely you're going to go on to do that. So with that said, welcome everybody again. It's a real honour and privilege on behalf of the whole team. And we're going to lead off today with Pam Mace, who I'll introduce, and then followed by that Santhi Ganesh. So Pam is an FMD patient herself, and this is public, so she won't mind me saying this. Pam's had a couple of events related to FMD. Pam is a dear friend of Santhi and myself. I've known Pam for over a decade. Pam, out of desperation for complete lack of knowledge about FMD, founded the Fibromuscular Disease Society of America. I don't know when, Pam, probably about 15 years ago now, you can tell us. But Pam has just been one of the most wonderful advocates for FMD and also for SCAD patients. Pam really, what we're doing today is very much modelled on what Pam set up by having patient days for FMDSA that always happen on the weekend of the Cleveland Marathon and come with intense pressure on all the participants to actually run in the Cleveland Marathon. So I'll hand it over to Pam and then we'll follow with Santhi. So Pam, Santhi, welcome so much and over to you. Thank you.
Thank you so much. So I can't see anyone. I know Jason there, I was able to see you guys before, but I'll just go ahead and go through my slides. So you can see my slide, okay?
Not yet. Not yet. Share screen again. Share again, Pam.
Okay, let me close this.
Oh, you should be able to see us now. We can see you, but not your slides yet, Pam.
I don't see. There we go.
Okay, it looks like it's coming. Yep, and just go into presenter mode. Perfect. Go right ahead, Pam. Thank you.
Well, thank you for inviting me to be here today. It's a true honor, and I enjoyed hearing all the chatter as you guys were setting up. It was actually a little emotional for me because I remember my first meeting, so I don't know how many of you are newly diagnosed and this is the first time that you've ever met someone else, but I think it's an amazing, heartwarming experience, and I'm glad to see that you're all here today. And so a little bit about me, I was diagnosed in 2000 and I had bilateral carotid dissections and I also dissected my left vertebral artery, 3 pseudoaneurysms, 2 TIAs, and since that time I have dissected my other vertebral artery, but I am doing very well. And so I can't express enough how important it is to stay on top of your care. And I think it's amazing that you guys have Jason there. We were very jealous when he left, but we get it, and we still see him in the United States occasionally, but we do miss having him here. And so a little bit about FMDSA. I don't know. My talk, I'm going to talk about a lot of different things, but FMD was actually diagnosed first in 1938. And so in 2000, I was able to find a group on a Yahoo support site, and we were all treated very differently. There were no experts, there was no organization. There were very few even papers that you could find, mostly case studies on FMD. And so it was a very scary time for all of us. And we knew that we needed to come together and form a group or an organization. And so that's how FMDSA got started. And I can tell you, we never dreamed that we would be where we are today or that so many patients would be getting diagnosed. And so we started off, I love this little table because this really is how we started, as a very small group. And so each opportunity, I'm a registered nurse, for those of you that don't know. And so it was really my nursing that opened up a lot of doors for us. And in 2006, I was invited to Belgium to meet with these geneticists. And I was in way over my head. Jason and Santhi can talk, and it still goes kind of right over my head. But what I had asked them about, back then was just to please put a name and a face to this disease and to help us. And FMD was considered a very rare disease. The first case, again, was diagnosed in 1938, and it was actually a little boy with the diagnosis. So think about the time from when I was diagnosed in 2000 and the first patient in 1938. So the disease was really neglected for all of those years. And so I actually was able to attend a genetics conference in 2006, and I met with more doctors, and these relationships have really helped us throughout the last 2 decades. And so when I was there, I was told about this paper, and I'd never seen it, the genetics of fibromuscular dysplasia. And so I contacted this physician, and he said to me, I know no more about this disease today than I did 30 years ago. And that was heartbreaking for me because I can tell you, like a lot of the other patients that I spoke with from our group, there was fear, there was anxiety, there was the unknown, there were no experts, there were no centers. And so it was a very scary time to actually be diagnosed with this disease. And even back then, we knew nothing about SCAD. It was on anyone's radar. And so FMD was considered a rare disease. And in 2006, I contacted the National Stroke Association, and they then listed FMD as a cause of stroke. I had shared my story, the story of other patients, and then the following year, the American Stroke Association came on board, and that's when we started to see more patients getting diagnosed with cerebral vascular FMD, so the carotid of the vertebrals versus the renal arteries. And we immediately saw our website hits go up and more patients contacting us that were getting diagnosed with the disease. And I just put these slides in here just to demonstrate how important the awareness and education is. And so in 1 year, we made the cover of 5 different magazines. And this was the article that really changed everything. It was the American Stroke Association, and they featured 3 patient stories that had dissected. And then we had a lot of neurologists then actually diagnosing the disease. And then that led to us being on page 1 of the Wall Street Journal, The Rare Disease That Isn't. And that back then, they estimated that 5% of Americans may be diagnosed with fibromuscular dysplasia.
So my address, so if you want me to send that to you when I fill out the form.
I can hear somebody talking. I'm not sure what that is. So anyways, then in 2009, Mystery Diagnosis contacted us, and my story aired on that. And again, we saw a direct hit in the patients that were getting diagnosed with the disease. And so this was a vascular conference that I was asked to speak at. And we knew at that point that how important a registry would be so that we could capture the data of all the patients being diagnosed. Because again, it was really primarily thought initially to be a renal disease. And so we knew that there was a lot that we didn't understand. And so when I was done speaking, I received a check for $50,000. And that actually helped us to launch the registry. And that was in 2009. And so here's just a little map in the United States. It's the North American Registry. We have 21 centers. One is actually in Canada. We have 2 centers in Ohio, and this has not been announced yet, but there is a third hospital system in Ohio now that's onboarding to be a registry center. So the state of Ohio is going to have 3 registry sites. Over 5,000 patients have participated, and so we're learning more and more about FMD. And I think the registry really helped. It got the attention of researchers around the world and physicians that had more interest in the disease. And so I just wanted to put a few slides in here. This was in 2011. Dr. Olin and I went and met with some researchers in France. And at that time, their registry was primarily all patients with renal FMD. And so this was an international conference that was held in Cleveland, Ohio, and then each conference led to another one. And this one was just amazing. This was in 2018, and Jason and Santi were there, and experts from all over the world. And this doesn't even include everyone. So you can see how we grew from that table initially in 2006 with 3 geneticists to this huge group here. And so then that led to a meeting in Poland, and then things kind of paused because of the pandemic. And so I'm just sharing these photos just to show you how much and how often we get together here with all of the physicians. And it really, for me, gives me so much hope for my future. But we meet at these meetings, the medical meetings, and we can discuss different projects that are going on, and we just keep things moving. And so this was last year at the American Heart Association. Santi and Jason were both also there, but they actually had a panel on FMD and SCAD. And so I was representing the FMD patients. Catherine Leon on the end right here was representing the SCAD patients, and she is from SCAD Alliance. And so that was a huge opportunity for us. And, you know, when you think about it, FMDSA was formed in 2003. It took till last year for the American Heart Association to invite us there. And I just put this on here because last year I always go around and talk to people just trying to raise awareness. And so in their hypertension educational materials, right here they have FMD. So any physician, any type of medical provider can go over to their booth and learn more about fibromuscular dysplasia. And so this just speaks to FMDSA and our work around the world again. That was Mount Sinai in New York. This is Nabila's lab in France. I was there last year. This is Dr. Ganesh's lab, and we work very closely with her, referring patients to participate in her study. Patients from the United States. And then I briefly wanted to mention this, besides our registry, and I think Dr. Ganesh will speak to some of this, but there's also the European registry, and they're growing pretty rapidly. And this was, since 2008, we hold in-person meetings. And so I just wanted to give you a glimpse of what this is. It's always a big meeting. It's exciting. The most important thing that we're asked from patients is they all want more time together. And so we've went to a 2-day, actually a 3-day event, but we hold a meet and greet. We have entertainment. We have a raffle. And then we also work with the physicians to do research studies. So, you know, there's one patient getting, well, both of them actually getting blood drawn. We do saliva collection. One year we actually had a group come in, and then they published a paper on living with fibromuscular dysplasia. And if anyone would like that, you can contact me and I will send that to you. And so the other thing that we did here, and I'm sure it's different, you know, in other countries and in Australia, but we designated May as Fibromuscular Dysplasia Awareness Month. So we have a lot of activities to raise awareness. And so we participate in multiple marathons to help support our programs, raising funds, but also awareness. And then at the top, I just included that's Dr. Jackie Saul, and she also works on SCAD, Catherine Leon from SCAD Alliance. And so we really do all work together. And I think it's a very important collaboration just so that we keep things moving and we're not recreating the wheels. And so there's Jason. He came from Australia and ran at one of our recent meetings. Right there in the middle is also someone from Australia who flew to Ohio. This is Dr. Brian Wells from Emory. And so the doctors really are involved with FMDSA. And so quickly, I know I just have a few minutes, I want to talk about some of the support that we have here. And we have a YouTube channel. We've got all kinds of information on our website. We have an Inspire support group, but all of this stuff can be downloaded. We put the most recent articles also on our website. And you can become a member of FMDSA. Just go to our website, and then you'll get, we try to do monthly newsletters. We've been a little bit slower, but just to keep you up to date on everything. And we also include things that are going on with SCAD and things that are happening around the state. And I just wanted to briefly mention this. This is a Dr. Heather Gornick quarterly does free webinars. The next one's coming up. It's November 18th. I know there's a time difference, but this one's going to be on pulsatile tinnitus. But then there's usually always time for questions, general questions afterwards. And we have patients from all over the world who actually participate in this. And this is, I'm sure Dr. Ganesh will talk about this, but this is very exciting. The LeDuc Foundation just awarded Santi and Jason $8.5 million to actually study FMD. And so we're really excited about that. There is going to be, I think, a meeting next November, and we're hoping that we're going to include a day for patients to actually attend that. And so stay tuned for more details on that. And then I also wanted to mention that for those of you, I don't know if everyone that's on here tonight is actually from Australia, but there are groups. I think there's only one other organization besides FMDSA, but there are Facebook pages for the Netherlands, Belgium, and actually the FMD, it's called BE. They've got a lot of materials in multiple languages. I think they're like 8 to 10 languages already. There's a UK, Ireland group. There's a group in Italy now, one in France, one in Poland. And we try to do everything that we can to work with them and support them and share materials. And I think it's important for, especially you guys in Australia, years ago, there was an association and they folded. The patient who started it her name was Bronte, and we had worked worked together for years, and she just didn't have enough help or resources to keep it going. So I do think it's very important for people to get involved. And I also know there's a lot of SCAD groups as well. But there are two women, if you're not familiar with them, and they run a actually Facebook group. So there's no longer a website in Australia. With the exception of what Victor Chang is doing, and they're doing an amazing job. But Chris and Kate run the FMDSA, and it's an Australian group. And they also wanted me to mention that I think it was last year that Jason had did a Q&A with them, and it was pretty long, and he actually answered probably all the questions that you guys would have. And so I would make sure that you do follow up if you have more questions after this meeting, and check that out. And so I thank everyone for having me here today. I just think it's amazing that you're all here. I'm very excited. I have a lot of hope for our future. So thank you.
Thank you so much, Pam. Again, it's an honor to have you with us. So if you could stop sharing screen, Pam, please. And just just come off screen share. And then Santhi, if you want to go ahead and share screen, I'll introduce you. And what we're going to do is break for questions after Santhi's talk, and then we'll let them go. So Santhi Ganesh I've known since 2006. When I first went to the States to do my postdoctoral training after my PhD. So Santhi was a postdoc in the laboratory of Professor Elizabeth Nabel, who at the time was the chief of the National Heart, Lung, Blood Institute of the United States. So Santhi and I ended up postdocs at the NIH together in the lab of Betsy Nabel. So we've basically known each other for 20 odd years. And, to Betsy's credit, Betsy at the time was saying this disease, fibromuscular dysplasia, nobody knows anything about it. If I was at my stage of career as you guys are now, I'd be studying this disease because there's a lot that we need to learn. So Santhi and I obviously listened to Betsy, and here we both are 20 years later, both working together on FMD and SCAD. And as Pam just announced, we were really thrilled a couple of months ago when we learned that the Leduc Foundation has awarded us $8.5 million US dollars, so that's about 12 million Australian, to study fibromuscular dysplasia and also some SCAD research. So that starts on the 1st of January next year. And Pam, I think you know this, but there will be a meeting of that consortium here. Probably it's going to be in 2028. But we'll have a whole bunch of international speakers, including Pam. I hope you'll be coming down, and Santhi, to do a face-to-face patient meeting with all of these international people. But that's a couple of years away yet. So with that said, Santhi and I, Santhi is a professor of internal medicine and human genetics at the University of Michigan at Ann Arbor. She's had a stellar career and has really been instrumental in helping us understand the genetics of fibromuscular dysplasia and SCAD. We share a close friendship, and Santhi and I are having Zoom meetings pretty much weekly. So we know each other well. We've written many papers together. And it's an honour and a privilege to welcome Santhi to speak to us today to give an overview of the genetics of FMD and SCAD. So Santhi, over to you. Thank you so much.
Thank you for that. Thank you for that kind introduction. I can see everybody in a small box, but I'll say I always enjoy talking about the topic of genetics, but need to be reminded and always welcome feedback from Pam and others on how to kind of frame all of these somewhat complex kind of concepts sometimes. So I'll try to keep this very high level. I have these disclosures, mostly peer-reviewed grants, and I'll start off by talking about SCAD. And just when we think about genetics, we're thinking about what is an individual's susceptibility to a problem. And so, we've talked about this overlap with fibromuscular dysplasia, and in some ways think of that as an underlying arterial process or arteriopathy. There are some what are considered cardiovascular risk factors that overlap with the condition of atherosclerosis, as Jason was mentioning in the introduction comments, such as hypertension and smoking, that may precipitate certain events, but not in everybody, and certainly not the cholesterol piece, diabetes, or other things that we think of when we think of atherosclerosis. More kind of relevant to what we'll talk about here is that there have been rare changes in the DNA sequence, so those are called variants, in specific genes that code for the connective tissue, certain elements of how cells talk to one another in the body. And there are a number of conditions associated with those that are in the category of connective tissue diseases. And we'll talk about those. And one of the more exciting findings in the last several years has been that there are also common changes. So what this means is 50% of the population may have an A or a G or a different specific base at that DNA sequence. And we all have those changes, probably, millions of these. But when you put them together and you add up multiple small changes, in aggregate, they can influence an individual's risk for a certain disease process. And we'll talk about that concept a bit too. And this is where the overlap of SCAD, FMD, migraine headache, hypertension, neck vessel dissections, carotid dissections, and so forth, we're seeing that on a molecular level, both with the rare variants and common variants. So we'll walk through some of that data. Because 90% of patients are women, and because of a preponderance of events around age 50 to 55 in many individuals. That's the mean age of presentation currently for FMD and SCAD, although there's quite a range on that. And some events that can be precipitated by pregnancy, a role of hormones has been hypothesized. And then when we think about what is actually happening in the blood vessel wall, there are endothelial cells that line the inner layer. There are muscle cells, they're called smooth muscle cells. Those muscle cells need to hang on to each other and a matrix around it, collagen matrix. And the function of those collagens and those smooth muscle cells is disrupted in these conditions. And so just to start out there, this is an image on the left of a carotid artery from somebody with FMD, where you can see kind of the pink is staining the muscle and the blue is staining the collagens. And in the inset, the black is what's called elastin. And I'll start out by showing on the right, actually, the normal configuration is that there are these nice layers of the muscle and then layers of the collagen and layers of the elastin that you can see kind of like the rings in a tree trunk or something along those lines, where they're concentric and go outwards. In FMD, that's very disrupted. The architecture is such that there's thickening and thinning of the media. There's kind of a different relationship. You can see those muscle pink stains are kind of conglomerated together, and the blue collagens are conglomerated together, and the normal architecture has been lost. So we think about, in this illustration, elastins, the smooth muscle, and the collagens. And this biology is important because it also gave us some ideas about where to kind of be paying attention in the signals. And one of the very exciting things is that as we're learning more about the genetics of SCAD and FMD, we are finding genes that impact exactly this set of biological units in the arterial wall. So when we think about genetic diseases, we're talking about those rare DNA variants that cause a single, gene type of disease. Examples of this is that Marfan syndrome or vascular Ehlers-Danlos syndrome, where a single change in a gene that can be inherited from parent to child is the underlying genetics. Usually you need only one copy of that change. So that's what the words autosomal dominant mean. Those are sort of technical terms for the inheritance. On the other side are those complex, those common DNA changes that many of us have, but if you have enough of them in the direction of risk, they can add up. And atherosclerotic disease is a good example of a disease with a very complex underlying genetic basis. And as we have learned more, both FMD and SCAD are complex as well. In both of these situations, there are contributions to familial risk. So we'll talk about that. The arterial involvement throughout the body may vary. So, even in a rare disorder with Marfan syndrome, there can be a lot of variability within a given family, even with the same exact genetic variant. And so we talk about that as a relationship to the disease. Having the variant doesn't always mean one will have a disease manifestation. And when it does manifest, it may look different than in different family members. So this is an overview just showing FMD in the circle on the left, SCAD in the circle on the right, vascular connective tissue diseases on top, and then cervical artery dissection, migraine headache. We wrote this paper and made this figure 4 years ago, and there's been more since then. So I always like to organize the genetics into a way that makes some sense for what we're talking about in terms of the rare versus common, but it's a little bit technical, and I'll just explain it. We won't talk about all the genes on this slide, but just to say there was maybe 1/10 of this a decade ago, and this is all from the more recent research in terms of the specific genes that are listed here. This is simply showing those rare variants have a higher chance of transmitting in the disease, all the way to the common variants in this brown circle that we detect using different research methods. So as an example of the international collaborations that Jason was telling you all about, the FMD GWAS meta-analysis, and Pam had outlined many of these groups very nicely in her talk. We had multiple countries contributing to the first what's called genome-wide association study of FMD. And here what we're doing is looking at millions of markers across the whole genetic code in as many patients as we can test with the disease, and then people without the disease. And then we compare which ones are more enriched in the patients with a disease. And so for FMD, this is a study that Nabila Boitier, Naji, and our group at Michigan co-led, but collaborating with Jason, Dr. Pursue, Drs. Olin, Dr. Gornick, many of the names that you heard Pam refer to. And we were so excited to see that the factor 1 locus, which is this top signal, had been described some years before as a candidate locus. It had been described actually for carotid artery dissection, and then new genetic findings. Similarly for SCAD, there has been, again, across all of the chromosomes, and where each study has done their own analysis, there's a method by which you can combine these data in what's called a meta-analysis. And there are about 20 or so hits here for SCAD, which is very exciting. Many of these are new understanding of genetics and biology that we need to think about. And some of these have some very interesting associations, more than we'll have time to talk about, but I'll call out just a couple of examples. One is we've done blood pressure studies in men versus women. And one of our loci, one of these regions with the collagen 4 genes is one that's specifically associated in women only, but not men, for blood pressure. And it's completely overlapping with SCAD and to some extent FMD. So we're very interested in following up signals like that. I'll describe, from Michigan, we've collaborated with Jackie Saw, and this was our GWAS with this very tall signal on chromosome 1 using various bioinformatic methods. These are very kind of technical computational methods. You can prioritize which gene is being driven by that genetic change. And in this case, it was this gene ADAMS-like4. And just as an example of how we like to think about these problems, we ask, is it expressed in a coronary artery? We use specialized methods to say, yes, it's the smooth muscle that is making this gene. So if it were to be too little or too much in a coronary artery, that could be a problem. And then the biology of this particular gene caught our eye because it interacts with fibrillin-1, the gene that's mutated in Marfan syndrome. So, and that's needed to make a mature matrix that holds together tissues. And so that's the most biological slide I'm going to show, but it's just an example of the kind of insights we're looking to gain. And what we want to do next is explore this and understand, what is that biology? Is it something we could treat with a medication, for example, or are there other ways to think about the disease that we weren't before? The other way we're taking our data is to take that I mentioned this cumulative risk. There's genetic risk scores. Here it's called a polygenic risk score, where you can add up how many of those subtle DNA changes does an individual have. And we've been able to construct polygenic risk scores. And when we take, for example, the SCAD polygenic score and run that across a large database that has every disease that's been coded in it, called the UK Biobank, and we ask, what does the SCAD genetics relate to? It was very positively associated with migraine headache. This was in some ways not a surprise. Many of our patients suffer from migraine headaches, and fairly significant migraine in some instances. And another thing that emerged was there was an association that was the opposite direction for atherosclerosis, meaning that the things that put one at risk for SCAD and to some extent FMD we have seen actually may be associated with decreased risk for atherosclerosis. And I think it's too early to say exactly what that means clinically, but it certainly mirrors what we've been observing, that it's not atherosclerosis that is precipitating a coronary dissection, for example. They really seem to be distinct processes, and the genetics are mirroring that. And so the concept is just, on one end of the spectrum, you might have cholesterol plaque. On the other, you might have more tendency towards dissection. And I thought I would highlight this study from investigators there that looked at this polygenic score in families and saw that it was actually associated with increased risk when there was a family with SCAD and more than 2 people. And so that's quite interesting. We don't always see that with polygenic scores. So whether these scores could be useful to predict who's at higher risk is a question that's been asked, but we don't really have quite enough data to say yet. But it's something we're interested in exploring. So the other piece of data that we have gone after is looking in families. And so we have a series of 73 patients with FMD. Many of these were enrolled at the FMDSA meeting down in Cleveland, and we reached out to patients, their family members, and looked to see how often did daughters of individuals with FMD get diagnosed with FMD. And in doing these kinds of calculations, you do have to assume a certain population risk that's known. And Pam, you mentioned the 5% number. So if we use those sorts of numbers, maybe it's between 2 and 3 times the population risk. So it's certainly not everybody, but we do see a signal there. The other signal we saw was that fathers of individuals with FMD sometimes more often had abdominal aortic aneurysms. And so we were able to use our polygenic scores to examine the associations between abdominal aortic aneurysm and FMD. And it really did support this idea that there's a shared genetic architecture, but it expresses differently in male versus female. And so I think our next question is why, and is this useful for us to think about clinically? Again, it's not quite at the point of influencing our thoughts of what to recommend, but from a biological perspective, we're very interested in this observation. And then finally, we described a few years ago a collagen 5A1 gene variant. It was an extremely rare variant that we found in 4 individuals worldwide. And there was a variety of presentations, SCAD, FMD. These patients seem to have more dissections than many. This is how collagens get put together. You have the DNA sequence that then tells you the amino acid sequence for a protein. And the collagen protein, where we have this GLY, that's a glycine, and that's really important for the structure of the collagen. And so when we looked at why these 4 individuals could have this same exact variant, our first question was, are they from the same family perhaps? And that was not the case. In fact, what it turned out to be is it was a shared ancestral segment of DNA. This change arose on that segment and then was passed to multiple people. So it is a finding that is what we call pathogenic. If there's time, I'll talk a little bit about just what that means in terms of genetic testing, but it was something that was annotated as if anyone's familiar with genetic testing, what we call variants of uncertain significance, and gave it some evidence that it actually could be a problem in terms of its ability to cause a genetic disease. So the question has been asked more frequently for SCAD, is this a manifestation of a known connective tissue disorder? I mentioned what some of those are. And these are all the different studies. We won't walk through all of them. There's too much data here. But I thought I would point out a couple of things that in a small subset of individuals, collagen 3A1, which corresponds to the disease vascular Ehlers-Danlos syndrome, had changes, mutations in the DNA sequence that qualified for this disease. Similarly, Loeys-Dietz syndrome, these are mutations in a certain set of genes that have to do with signaling in the cells. And there's definitely, we see examples of this. In total, across these studies, it was approximately 5% of individuals had rare variants like these underlying their SCAD. So when we think about genetics in the clinic, I thought I would walk through this in just a couple of slides. We think about an individual's personal history, what are their manifestations, especially if there have been recurrent dissections. That is one that will catch our ear. And I think, practice is a bit different in each country, but when there's been recurrent dissections, we tend to think about doing genetic testing. If there's been a concurrent aneurysm or dissection of the aorta, we look at an individual's pregnancy history, their surgical history, their family history. We're obviously listening for FMD dissections and aneurysms. Many of these diagnoses require imaging, and some of the older generations sometimes have not had it. So just listening for what are the symptoms and what have been manifestations, such as a heart attack at a young age, for example. Recurrent SCAD, it definitely counts. There's some features of the SCAD in terms of its severity that may sometimes influence us. And then the imaging patterns, when we do a head through pelvis set of imaging using CAT scan or MRI, we will look at what we find there and determine if this is a particularly heavy burden of disease, for example. And so we think about genetic testing for diagnosis, prognosis, treatment planning, counseling, especially on familial risk. And, if we had to put down a list of genes that we're thinking about for FMD and SCAD that count in this rare disease category, this would be that sort of list. The outcomes of genetic testing is that it can be completely negative. You didn't find any genetic variants of concern. It's positive in that a variant annotated as pathogenic or likely pathogenic was found. Or like I mentioned, where we started with the collagen 5A1 variant, it's called a variant of uncertain significance. We don't really have enough information to say if it's a problem, and we don't really have enough information to say that we don't need to worry about that. And then just to quickly walk through the types of rare disease genes we're thinking about, this is the list, kind of organized by whether it affects the matrix, whether it affects the cells themselves. And there are a number of key features that we look for to suggest some of these syndromes. So for Marfan syndrome, dislocation of the lens, some of the tall stature and other things, vascular Ehlers-Danlos, there's a list of these here, and for Loeys-Dietz syndrome. So I believe these slides might be available later, but just for you to know, there's a list of things that people are thinking about in clinic when you're being seen. And if these are noted, that would influence whether we would think about genetic testing. So just to summarize, a lot of information in this field, and I hope it wasn't too technical, but just to really boil it all down, the familial pattern is typically the rare inherited variants. They're pretty infrequent. So in SCAD, around 5% or so, maybe 6, 7, 8% in the series that have been published. We tend to think that the manifestations are more severe in terms of the arterial disease, and we think about the vascular connective tissue. What's called a sporadic pattern, which is an individual who may not have a family history, that is the majority of FMD and the majority of SCAD. We think these could be single genes or multiple genes acting together. Small effects per gene that need to add up over enough of those effects. And then beyond that, there are also ways that genes interact with each other, a person's genetic makeup interacts with the environment. So there really is a lot of complexity to this. And then associations with risk for other disease is something we're thinking about, so we can be prepared for what we need to be thinking about and really try to understand these disease patterns. So I always like to show my lab team this, the work that I presented that was research oriented is certainly not only my own, but a whole team of individuals. And I'll stop there, and I think we'll have some time for questions.
Fantastic. Thank you, Santhi. We probably gave you the impossible job to explain the genetics of all of that to us in 20 minutes. So a fantastic talk, and I'm sure there's going to be a bunch of questions. Just a shout out, so the next FMDSA meeting, likely, it's not confirmed yet, but will probably be at Santhi's institution at University of Michigan in Ann Arbor, probably early November next year, so 13 months from now, roughly. So it's to be confirmed, but it'll be really exciting, and we'll all be there to talk. And it's as Pam said, it's a couple of days of this kind of interaction with lots of patients. So if you ever wanted to go to Ann Arbor, Michigan, watch the football, Santhi describes it as grown men crashing into each other, but this is your chance, so time to start playing. So any questions? I'm sure there's a bunch. Please, go ahead.
Thank you so much. Just a question about the gene changes. Is there any evidence to suggest a difference between congenital genetic makeup and variants caused by environmental factors? Do we know what environmental factors might be contributing to some of those gene changes?
Could you hear that, Santhi?
I did. That's an
Right.
excellent question. And I think it's very hard to study environmental factors, to quantify them and really study it. Probably the best shot we have is to study changes on the DNA that occur with certain environmental exposures, and those are studies that have yet to be done. So I think the kinds of environmental exposures we could think about are things that drive hypertension. So for dissections, we always want people to maintain a very nice normal blood pressure after having been diagnosed with one of these conditions, that's so that there isn't extra stress on the vessel wall. I tend to think of hypertension as having a very strong environmental component because of the diet and certain things that can influence it. The other might be smoking, right? Really to make sure that there's avoidance of any cigarette smoke inhalation, because we know that turns on enzymes that sort of chew on collagens actually in the vessel wall. I believe your question was beyond even those, and I think the answer is we don't know right now, but we're wondering if those are things we should be studying more methodically.
Great. Yeah, Bruce.
I've got two questions. There was a reference to tinnitus. I just want to know the relevance of that. So I don't understand how tinnitus is relevant. And the second thing is about the use of statins. And people who have a higher cholesterol are given statins to lower their cholesterol. But if you're an FMD sufferer, should you be looking at that? Because if the statins are lowering your cholesterol and your vessels are becoming more less flexible or something, I'm not a doctor, I don't quite know the terms. Is it contraindication to use statins if you've got FMD?
Mm-hmm. Mm-hmm.
The tinnitus and statins, Santhi.
Yeah. Well, Pam, do you want to take the tinnitus one? You showed the whooshers, the whooshers slide.
Yeah, so I'll let you can get more into detail with it, but a lot of the patients, it was one of the things that we noticed early on when we started following patients, that a lot of patients complained of the swishing noise in the ear. And actually mine started when I dissected, and it was severe. It's very disruptive. You can go to the website called whooshers.com. And she actually has video recordings of people's pulsatile tinnitus that you can hear. They've got a lot of resources on there. There's a lot of research being done in California on it. I would highly suggest, if you have it, participating in that next webinar. But mine, as my arteries healed, stopped. And so I only hear it if I'm extremely exhausted or stressed, which it's maybe only a couple times a year now versus when my arteries were still healing, it was daily. And so Santi, I don't know what you want to add to that.
Yeah, I mean, I think it's a really interesting thing. And the folks who really, set up and have been leading the clinical registry, Pam, really credit you and patients for speaking up about the symptoms, right, that you're experiencing. And only when asking realized a lot of people with FMD have the pulsatile tinnitus, so a swooshing sound in their ear, either intermittently or chronically, and it doesn't always correlate with the presence of beating in the artery. And so and then we talk to patients about the change, if it was there and it went quiet, or if it was never there and you started noticing it. I think for the second question about statins, it's interesting. As we see so many patients who've been hospitalized with a heart attack and then are coming out of the hospital, it's quite common that they're on a statin medication. I'm more often stopping that in my own clinic than I am starting it, because what we understand about these diseases is it really is not mediated by cholesterol accumulation in the blood vessel. And so the way we think of statins is just as if you would do it for primary prevention of atherosclerosis. So primary prevention meaning before the onset of any atherosclerotic disease. If you are somebody who qualifies for a statin according to the guidelines, that should be done. Having FMD or SCAD is not a contraindication to it. I think your question is actually a really good one about what is the relationship between lipids and how the blood vessel is functioning and the stiffness and so forth. In general, we don't want people accumulating cholesterol plaque, but the age at which many of our patients are presenting, their profiles, many are very normal, their lipid levels. If we see a patient who's immediately postpartum, if they're still lactating, personally, I don't make a lot of long-term decisions based on those kinds of numbers that we might see that are a bit elevated. Usually those come down afterwards. So it's really a distinct process, and it's something that is very different from what statins are trying to treat.
We've got time for one or two more questions, and then we'll have to let them go. Yeah, go ahead.
So if the familial link is rare, what's the percentage that two siblings could have just sporadic, random, sporadic, completely unrelated? Do we have stats on that?
It's a good question. So if it's not a rare disease gene and you're looking at two siblings, I mean, I would say that's a notable family history. So what is hard to quantify is if you have, let's say, 20 small changes in your DNA that have increased your risk for SCAD, your sibling is likely to share many of those. So it's highly likely that there are shared, what we call complex contributions to SCAD risk. So I think maybe that's a little bit of a reversed way of answering your question that you were asking. What are the odds that it wouldn't be? I tend to think that there probably are some shared genetics under there. Yeah.
So Santi, one of the questions that, sorry, Jason, one of the questions that we get a lot is, should I have genetic testing done and should my family members be tested? And can you speak to that?
Yeah. So if an individual has features that are concerning, and I would say for SCAD, we could talk about where exactly to set that threshold. I think in somebody with any arterial dissection, we're always thinking about, could this be an underlying connective tissue disease that's manifesting as SCAD for the first time? That's almost always a question. And there are things on exam and things based in the history that can be reassuring or more concerning. So if we hear any of those red flags on an exam, if somebody has had a history of a pneumothorax, a dropped lung, for example, if it's a recurrent dissection, this is their second or their third dissection, we would most definitely be thinking about doing the testing. Typically, it's a whole panel of genes that are tested at the same time. I think, in FMD, it's not very common that we're testing if it's just the arterial beating. For the collagen 5A1, there were features like a lot of neck vessel tortuosity that I didn't talk about, but would influence my own thinking about, is this somebody I'm worried about that particular variant? But in patients with FMD with multiple dissections, I think it is worth thinking about that. So if people have had 2 or more dissections, we're thinking about that. And I think that's, you know, what that individual, what our recommendation is, what their family history looks like, what their physical exam looks like, all kind of influence whether to proceed or not.
Okay, one last question we've got time for. Thanks, Santhi. Any last questions?
No one else?
Yeah, go ahead.
You mentioned smoking as a risk factor. There's more and more being written now, certainly in Australia, about the influence of alcohol on health and particularly blood pressure. Can you comment on alcohol risk?
I'm not aware of any data documenting risk for FMD and SCAD complications. I don't know, Pam or Jason, if you've heard of anything, but I haven't seen any.
No, I haven't. Someone's incriminating themselves in the audience. Pam, Santhi, thank you so much from all of us. It's just been a thrill and a pleasure to have you on. We'll let you get on with your Friday night over there. Look forward to seeing you both in the States soon. And all of us, please join in thanking them for
Thank you.
Thanks, everyone.
And I want to quickly mention, for a lot of the questions you guys have, there's an international consensus paper on fibromuscular dysplasia. It's free. It's 20-some pages long, but I think it'll answer a lot of the questions you have. So again, it's the international consensus on fibromuscular dysplasia. And then there's also a scientific statement on SCAD. So I think those are some good papers for you guys to look at, to use as resources. And I hope you have an amazing day. I have no doubt that you will.
Thank you. All right. Good night.
Bye.
So we're going to move right ahead, and I'm going to call on Bob Graham unannounced, because the next 2 speakers are actually from Bob's lab. So Bob, as you know, I'm the director of the Chang Institute. Bob was the inaugural director of the institute that I took over from. And Bob's going to introduce the next 2 speakers, which is Lucy and Ingrid. They're going to talk about work done in his lab. So over to you, Bob.
Yeah, sure. Thanks, and welcome everyone, and thanks for coming. Hopefully you'll find this useful, and we certainly appreciate your attendance. So look, the next speaker is Lucy McGrath-Cadell. Lucy is a cardiologist who has been doing a PhD with us, with Jason and myself, and we're very proud of what she's achieved. She's just submitted her thesis, and she's going to tell you about some of the work that she's been doing on SCAD. Thanks, Lucy.
Thanks very much for the introduction, Bob. It's an honour to be here and speaking with you all today about a topic that's very dear to my heart. I've been working on spontaneous coronary artery dissection now for, I worked out around 10 years, first in sort of the clinical setting, and then as part of a PhD with Professors Bob Graham and Jason Kovacic, as well as Eleni Gianolatu here. So I'll be giving a general overview of spontaneous coronary artery dissection, as well as talking about some findings that are actually unpublished of an imaging study that I undertook with some collaborators at UNSW who were bioengineers, and we found some interesting findings. I'd like to also acknowledge the traditional owners of the land on which we're meeting today. So in terms of spontaneous coronary artery dissection, what actually occurs in that condition, and many of you will be aware that it's a condition of the heart or coronary arteries, and they're vessels which supply the heart muscle with blood flow and oxygen. And you can see in the diagram there on the right-hand side, there's 3 major coronary vessels. So the left anterior descending coronary artery, the left circumflex coronary artery, and the right coronary artery. And there's several branch vessels coming off those main arteries. And what occurs in spontaneous coronary artery dissection is a bleed within the layers of the artery wall. So the primary event which occurs is actually, in most cases, a bleed, and there can be sort of secondary consequences of that. And that bleed then causes an arterial blockage, which is either partial or complete, and reduced blood flow to the area of heart muscle which is supplied by that coronary artery. And unfortunately, heart muscle cells may die as a consequence of that blockage. And clinically, we see spontaneous coronary artery dissection presenting as a heart attack or related complications of the reduced blood flow. So these are some diagrams showing on the left-hand side a bleed in the heart artery wall, and that bleed is obscuring the blood flow within the heart artery. And that's what we see in 70% of cases on the coronary angiogram. So we see that there's reduced blood flow, but there's no connecting point between the bleed in the wall with the blood flow in the artery itself. And in 30% of cases, we see what's on the right-hand side of the screen. So that's where there is some disruption of the lining within the coronary artery, so that we call that the endothelial lining. And that also results in an obscuring of blood flow in the heart artery wall. This schematic is a little misleading in that those cases on the right-hand side also have a bleed in the heart artery wall itself in most cases. So it's just differentiating between those with disruption of the inner lining of the heart artery and those without. So this is an overview of the characteristics that are commonly seen in patients who've had a SCAD, as well as what we know about the disease associations, many of which have already been mentioned by Dr Santhi Ganesh in her talk. But we've recognised in many cohorts internationally that 90% or more of patients presenting with SCAD are female, but that still leaves 10% or more being male as well. And there's some recognised associations with spontaneous coronary artery dissection. So they include exercise, certain types of heavy, strenuous exercise, so things that suddenly increase blood pressure and consequently shear stress, which I'll talk as a concept. I'll talk to as a concept in a bit later. But there's also recognised emotional stressors, and this is not in all cases, but in many cases throughout several cohorts, there's been triggers of physical and emotional stress. There's a recognised association with pregnancy, SCAD being the most common cause of heart attack in people who are pregnant or having just delivered a baby. Migraine, as already mentioned, with some recognised association clinically as well as in the genetics. And fibromuscular dysplasia is the other image there, as we're all well aware now with those initial two talks we had today. There's recognised lower rates, and that's lower rates compared to patients who've had an atherosclerotic acute coronary syndrome or an atherosclerotic heart attack. So we know there's lower rates of diabetes, smoking and hypercholesterolemia. So SCAD is a very different condition to atherosclerotic coronary artery disease. And that's reflected and explained already in the genetics also. So in terms of management, there's current data from registries which suggest that less blood thinning agents are in most cases better. So these are all observational studies. So they weren't randomized in the sense of one patient receiving more antiplatelets or more blood thinning and one patient receiving less blood thinning. They were just an observation of what occurred in real life. However, there's an indication that less blood thinning agents may be preferred in spontaneous coronary artery dissection. There's conflicting evidence for beta blockers. So there were some early registry studies showing that beta blocker use observationally resulted in better outcomes in terms of reducing recurrence. However, in a more recent registry, it was a neutral effect. But mechanistically, in terms of reducing arterial wall shear stress, beta blockers seem to make sense in this condition. And there is actually a randomized controlled trial that's been undertaken in Spain, and the results are not yet published. So we're looking forward to that in terms of informing beta blocker use. And controlling blood pressure is important. So that's been consistently shown across registries that in patients who've had one SCAD event, it's important to control blood pressure to improve outcomes. Cardiac rehabilitation is generally recommended, but in some work done through our group and some collaborators, there's a patient preference for cardiac-specific rehabilitation, which I'm not yet aware of any groups doing within Australia, but we're hoping to get that established. And psychological support program has been developed with the VASC cohort here at the Institute and some collaborators in Melbourne with some researchers from our group as well. So moving on to the VCCRI arteriopathies and SCAD cohort, thanks to Ingrid Tarr for this slide. We've since our inception in around 2017, we've been lucky enough to grow our cohort here to 667 patients with SCAD, and the majority of which have been confirmed on angiogram. So 560 rather have been confirmed to date. A lot of our recruitment has been very patient driven. So thank you to members of the audience today. Through social media, as well as self-referral to our cohort, and cardiologist recruitment as well. And on the right-hand side, you can see that we have some substantial genetics data, which we've been contributing to international studies, as already mentioned. So we have 216 people within our cohort who've had whole genome sequencing, that's WGS. And 395 have had DNA microarray. So that's to look for the common variants or the polygenic risk. And you can see the breakdown there. So sort of as expected, 617 women and 50 men, which is in keeping with the proportions in other cohorts internationally. The mean age of SCAD was 49 years in women and 47 years in men. We have 15 people who've had a recurrent SCAD event, which we're looking at with some detail to determine what characteristics are different in this group. And we've recognised a family history of 2 or more relatives with spontaneous coronary artery dissection in 10% of our cohort. So moving on to an imaging study, which formed a substantial portion of my PhD. So it's interesting that we know a lot now about the genetics. I mean, there's still a lot to be determined, but we know that the coronary artery wall and the makeup of that coronary artery wall is likely to make an individual with SCAD more vulnerable to the dissection event in the first instance. But what we don't know is why a specific area within the coronary artery wall is affected with the SCAD. So that's what we aimed to start to answer with this study. So why does SCAD occur at a particular location within the heart arteries? And our hypothesis was that local vessel anatomy and wall shear stress contribute. And just to explain that, wall shear stress is the tangential force of the blood, so the blood flow exerting a force on the inner lining or the endothelial lining of the coronary artery. So the methods we used in this study, and I should acknowledge Associate Professor Susan Bayer and Dr Mingzi Zhang also in this work because they were equal contributors. We collated CT coronary angiograms from the people within our cohort who had already had those studies as part of their routine care and were happy to participate in this study. So we de-identified those images and then created coronary tree models. So you can see that on the next item down on the flow chart. And in the yellow is the segments which have been carefully demarcated to be affected by SCAD, and that was compared to the invasive coronary angiogram, so carefully marking out those affected segments. And then some really technical analysis was done using the expertise of Dr. Mingzi Zhang, looking at certain characteristics of the artery. So we looked at curvature, diameter, torsion, as well as time average endothelial shear stress, which is essentially an average measure of that endothelial shear stress or the stress of the blood flow exerting on the inner lining of the artery. And we looked at the variability or a measure of variability of that shear stress also. And these are the comparisons that we made. So in the first box up the top, we compared the whole SCAD affected tree. So we had 36 scans and 41 SCAD affected lesions. And we compared the whole of the coronary artery tree that had the SCAD with a control population. And that control population encompassed 75 scans. And those were people that didn't have any coronary artery disease or calcification or history of SCAD. So that was the first comparison. So the left or the right coronary tree with the control group. The second comparison was in the artery that was affected by SCAD. So one of those three major arteries I mentioned earlier. So the left anterior descending left circumflexor right coronary artery, comparing that between the SCAD affected territory, so in the 36 SCAD cases compared to the control. So that was the second comparison. And the third comparison was looking at the SCAD affected segment and then comparing with that individual, so within that individual's anatomy to the non-SCAD affected segments. And this all showed some very interesting but not overly surprising results, that the arteries with SCAD, when compared to the control group, so the 75 controls, had smaller diameters, higher curvature, and higher and more variable wall shear stress. And then in the segments with SCAD compared to the remaining unaffected segments, so within that individual's coronary tree, the SCAD affected segment had smaller diameters and higher and more variable wall shear stress. So these are really interesting findings because it's the first time in any model system of any kind and compared with controls that there's been the implication of wall shear stress in terms of the degree of wall shear stress and the variability. So there's some implications potentially clinically with this data that it does support those recommendations that I'm sure many of you have been informed of avoiding heavy lifting and straining as much as feasible, and in good blood pressure control. So they're things that are often advised clinically, but now we have some mechanistic support for that. And we're hoping from this data that we can translate this into diagnostic imaging tools for SCAD, or even prognostic imaging tools for SCAD. So there's a move internationally towards less invasive ways of diagnosing spontaneous coronary artery dissection. So CT scans rather than invasive angiograms. And we're hoping that these findings can be replicated and then hopefully integrated into such tools to benefit SCAD patients. That's all I had to say today. Thank you. Oh, yeah. Pull them with Ingrid.
Oh, okay, at the end, okay.
Yeah, thanks.
All right, so look, let's move on then to the next presentations by Ingrid Tarr. So Ingrid is doing a PhD with us, with both Eleni Gianolato, my colleague who's got all the smarts and does all the complex genetics. And Ingrid's doing a great job and she's going to talk about some of her work. Thanks, Ingrid.
Thank you, Bob, for that. I've actually had the pleasure now of working with Bob and Eleni here at the Institute for coming up on 10 years. So as sort of a research assistant prior to this current PhD. Thanks. And what I'm going to talk today about is sort of a bit more of a concept of how we actually do these studies. I'm going to be talking about, this is the genetic studies that Lucy already alluded to with the DNA that we've collected as part of the VASC study generally, and we'll come at the end to some of the things, the what's that we've found from this. But the nature of SCAD genetic research is it is very internationally collaborative. So Santhi's also already touched on many of those findings already. So hopefully this will just help fill in some of the gaps of like how we get there and what it might mean. Okay, so first, so there's two components to this talk, of course. There's the how we actually do the genetic study and then what our studies have shown us. And if we start, of course, with the how we do a study, sort of the basic outline is we start with our patient participants or our control participants, and we sort of work through a process of arriving at our analysis and our statistics. To a participant, some part of this is pretty obvious, I think, which is how we will go about recruitment and the sample donation process. And then we move into the much more mystical kind of parts of science. So if we think about moving from sort of the patient stage, recruitment, sample donation, some of these are relatively quick. For example, sample donation from a participant point of view, maybe a couple of minutes. Recruitment can be a bit more complicated, as Stephanie knows very well, and might take weeks, hopefully not longer than weeks. And then we move into sort of this physical DNA, as I like to think of it, part where we have a sample, we're extracting DNA, we're doing what I'm going to refer to as genotyping prep, and I'll come back to that in a minute, and then we move on to doing our actual genotyping. This part is should be relatively straightforward, and sort of each step might take hands-on time, a couple of hours to a day. But then we move into the real, what I think of as the real meat of the work, which is when we're working with sort of the digital DNA data. And there's sort of like two broad components to that work. Firstly, sort of the bioinformatics, which again, Santhi kind of alluded to, but I'll come back to in a second, followed by sort of the real analysis of the genetic data and the statistics. And these stages can be sort of weeks to months to sometimes, but hopefully not years of work. And the other thing that I think is kind of to conceptualize some of this is in the lab, what I think people think about when they see scientists as people in lab coats and they're like dealing with that's wet lab. And that's an important part of this process. But actually, most of this work is what we call dry lab, and that means it's computational. But ultimately, the goal with any of this work as well, this genetic studies, is that the results that we find will feed back into sort of course, the clinic, but also the wet lab for further research, for understanding of what's actually happening, and potentially into animal or cell models of disease. So briefly sort of going through these stages, of course, we've got the participant stage, we've got Stephanie, who does a lot of talking to individuals, getting the necessary clinical and other data, followed by sample donation, which for anybody who's done it before is usually a bit of cheek tissue. Once we have that little bit of cheek tissue through mouthwash sampling or a little swab, that comes back into the lab, and as you can see, Suri is usually tasked with taking that sample and breaking down the actual cells through sort of, a process of heat and chemicals and extracting the DNA from within. Because once we have that purified DNA, then we get to start moving towards the exciting things of genotyping. I have to say that I know this photo shows Bob standing there supervising, but I don't think Bob is doing that very often. So I have personally never had Bob come and stand over me while I'm doing an analysis. So. But what genotyping actually means is if we think about DNA, we have this picture that we just have a double helix. Each of these little letters on that is representing one of the 4 possible letters of the DNA alphabet, A, C, T, or G. And what genotyping as a broad concept means is understanding which of those letters is represented at a position. If it is, for example, this A or this, to read this little section of the DNA would be, we have genotyped each of those positions as A, T, G, C, G, A, C, T, as per the bottom line. As part of preparing for genotyping, what we have to do is make a decision about how to genotype. Lucy mentioned that we have both whole genome sequencing data and we have what we call DNA microarrays. So this is actually a pretty important stage of things because we can ask different questions from these two types of data. What DNA microarray offers is a sort of a more sparse set of genotypes across a person's DNA, but it is fast and cheap to do. And we can still ask a lot of good questions. The alternative is we can do this whole genome sequencing where we're looking at the entirety of a person's DNA, which gives us more information, also costs a lot more. So there's always a balance of what questions we want to be able to ask, which informs the specific study approach we're going to take. Once we've made our decisions, we've got everything ready, we're sure that our DNA is good, we actually do the genotyping. And when I say we do the genotyping, I mean we send it across to the Garvin to do the genotyping for us. And they are basically using some very, very expensive fancy machinery and like kits, we would call them, I guess, where they are taking this DNA, they sort of break it up into small, very small chunks that are small enough that we can actually read them. Conceptually, it's just very, you can't really, with most methods, read everything all at once. We have to sort of break it up and then we can read what is on that piece of puzzle. And that's when it gets really hard because now we know what a puzzle says, but now we have to put all those puzzles back together to actually get one single picture. And this is when we move into sort of this digital DNA, really hard, really slow process. And the sort of the key component or the key outcome from the bioinformatics stage is having this completed set of sequencing. This, as I said, very hard. This no longer happens in-house. Our computer lab upstairs, but the computers we're actually using is this supercomputer down in Canberra as part of the National Computational Infrastructure. So this supercomputer is called Gardy, and it's where the data lives, it's where all the analysis happens. At the point that we have got whole genome sequencing from a patient, it's just the size of the data and the power of the computer required to be able to analyze it is just beyond what is really conceivable on sort of a laptop or a desktop, especially once we've got multiple individuals. And so the goal at the bioinformatics stage is really we take all these puzzle pieces back together and we try and construct it into one sequence using a lot of different algorithms. So we've also at this point got a whole lot of extra skills that are required, like it's very computer science-y background for many people, or like a strong sort of computational learning curve people, as it was for me when I started. I'm a basic biologist by training, so it was, I feel like I've never quite forgotten the pain of having to come and learn some of those skills. But to sort of like stress just how much data this process results in. For the average human, once we have sequenced the entire genome, we are looking at, or for the average human's genome, not even about sequencing, what we see is it is the size of about 3.2 billion base pairs, where base pairs are sort of, you know, the A and the T combo on this. And in whole genome sequencing, we don't just look at each position once, we try and look at each position on average 30 times. So one human genome alone, just in terms of the actual reads of the base pair, it's insane, but there's also a lot of data that goes along with it. And again, we're doing this for hundreds of people. And again, if we're trying to understand the genetics of disease, we can't, I don't even want to think about how hard it would be to try and look across all 3.2 billion positions at once. So what we actually do is we bring it down to what are called variants. And Santhi mentioned variants before, but this is basically, we take our entire constructed genome and we compare it to the so-called human reference genome. So if we think about this process as per this illustration at the top, if the reference is this sort of in black on the bottom, and one single patient's data is in red, what we can see is that sometimes the data from the patient differs from our reference. So this is what a variant is. It's a time when someone's DNA is different from our reference. And what we see in an individual level is that most people have about 4 million single letter changes like this across their entire genome, as well as other genetic changes, but that's the sort of the simplest version of them. And just for a little bit of context for you all, most people will have about 160,000 variants that are relatively rare in the population. So maybe only about 5% of other people will have any one of those 160,000. And it's probably a bit less, but it's in the ballpark of about 14,000 single letter changes that will be unique to a given person. And the thing to remember about this is those are still quite large numbers, but the vast majority of those, we don't really think they have any biological consequence. So it's really a matter with all of this work of just trying to like filter out all of this noise and get to the very small number of changes that we think are actually relevant to SCAD in this instance. And again, this is why it's supercomputer kind of work, and it's just it's a big jobs. Now, I guess the other thing to say is one of the problems, which Julia and the media team will know very well, is on the whole, the sort of dry lab computational work is not very photogenic. So I mean, this is this is a pretty accurate picture of what it looks like to be in the dry lab. But on the whole, people don't really. It's not interesting to show photos of someone sitting at a computer. But it is the reality. But at this point, once we have sort of constructed our set of, we know what the variants are for an individual, we can actually start, we can finally, months, possibly years into this process, we can really start to ask which of those variants are really important for the trait that we're interested in for SCAD. So it gets still very, very computational, but that's okay. But so that's sort of basically how we're going through this pipeline. We're at this point and we can ask, there's lots of different questions we can ask, and that relates to, of course, what specific approach we have taken to get the data, but also there's just so many different ways we can think about genetics. And sort of the things that Santhi was presenting was also showing sort of the diversity of information that we can be learning just from genetic data plus the clinical or patient data that has been provided to us early. And I mean, how that combines with other things such as the work Lucy's doing, or, you know, environmental factors is all a big part of where this work would go. So with that sort of like a how we do it, I was going to touch very briefly on what our studies have shown so far. So talking about specifically the work that's come out of our cohort here at the Institute. And Santhi also sort of broke it down into these two different kind of mechanisms where it's potentially a single variant or a single gene is important for disease. And when we look at that part of our studies, we've sort of, I think we've reached a couple of really important conclusions, which is that we do see these variants in the genes that are important for connective tissue diseases. That's what Santhi was mentioning. We see that, similar to what Santhi said, you know, it's very few patients on the whole who have that. It's sort of under probably 5%. And very recently, Lucy has also shown that some of our patients who have got usually a family history of aortic dissection are more likely to sort of have this perhaps as a mechanism underlying their disease. And I'm really just talking up Lucy's work here because also it's very good, but also has recently suggested that COL3A1 is probably the first real SCAD gene sort of independent of all of these connective tissue disorder associations. But sort of I think the main conclusions that are important from this clinically is that there is not a single SCAD gene. It's much more complicated than that. But also that to have a SCAD gene or a variant in one of these genes, it really doesn't mean that SCAD is inevitable. It's just much more complicated than that. And some of that is probably there'll be other genetic factors, but there'll also be environmental factors, and there's still a lot for us to learn there. So then if we think about sort of the other side of the spectrum, which is there are maybe multiple variants, and individually those variants aren't having a huge effect. We have gone in the last, about 6 years now, from having the very first such variant, which is the variant in a part of the genome that is related to the genes EGN1 or factor 1, which I actually know Nicole is going to talk a little bit more about after this. We've gone from that to then finding another 16 variants across the entire genome, which Santhi also mentioned. And now that we have the sort of bigger picture of what is happening, these small changes, again, we can look at the polygenic risk score, which Santhi also mentioned. So she set me up very well. And she also alluded to the fact that we have led a study that has shown that this polygenic risk seems to be kind of important for everybody, whether there is maybe SCAD families, so families who've got multiple SCAD events, or just people from the, who've got no real history or reason to otherwise believe that that's the case. But the thing to really, really keep in mind with polygenic risk is every single person, all of us in the room, all of us and everywhere, everybody's got some amount of risk. So again, we think that the small effect variants are really probably maybe the more important genetic component to SCAD, but that having this high risk really doesn't mean that SCAD is inevitable, because a healthy person on the street can still have high risk. It isn't it isn't a determining factor as such. It's sort of a part of the story. And at this point, there's also still a lot of questions that we haven't answered about it. For example, the biology that means those variants are contributing to risk, we don't really understand that at all yet. So sort of where we are now is we've got the sort of a rare variant thing. We're starting to identify individual genes that might be important, and we're putting together these common variants and how that might be impacting risk. But there's so many questions that we're interested in. We've sort of focused thus far, because SCAD genetic research is so new, on just what are the variants that are linked to SCAD. But of course, there are so many other questions that we are interested in or are currently actively pursuing, which I'm going to leave as a teaser for come back next year, and hopefully we'll have more to tell you. But so things like, there are likely to be ways that, like combinations of these variants that are probably important to SCAD. And we and also some of our international collaborators are currently really interested in how genetically these diseases are related to each other. And I think that's going to be very exciting in the next year or so to see that work come out. But then, of course, the more clinical, it would be very exciting to be able to get to a point where we can understand how these variants might inform treatment or prevention for patients on an individual level. But yeah, so these are some sort of examples of questions, broad questions that we're still really excited about and we're currently kind of working on. But ultimately, this is the first part in understanding SCAD better, because the fundamental question that we're trying to get to is, well, how are these variants actually affecting disease, and what can we learn from that will feed back into helping everybody in the room. And that's, again, something that Nicole is going to give us a little bit of an insight into. So with that, I'd just like to say thank you. It's lovely to be here and see all of you today.
Thanks, Ingrid. So look, we'll take some questions. I mean, one thing that a lot of people ask me is, if I have a SCAD, what are the chances my children will get it as well? And maybe you want to address that quickly?
I don't know if there's a simple answer to that, but on the whole, what we've seen is that it's very unlikely that you are passing on a single gene for SCAD, which means your child is likely to get it. So we just don't think it's the case that you having it is going to have a kind of surefire chance in any capacity that a child will also have it. Is that unacceptable?
Yep, yeah, I mean, I think the important message is it's less likely that you're going to pass it on if you're one of these people that have many different genes that contributed to giving you SCAD, yeah? Because you have to inherit a whole lot of different genes, all of which have a small effect. So you're probably less likely than if you, say, have Marfan syndrome, where there's only a single gene involved. So that's probably the good news. The bad news is it makes it a lot harder for us because we have to try and look at all these different genes that are contributing. Yes.
Firstly, congratulations to Ingrid and Lucy for taking incredibly complex topics and explaining them simply. That takes an awful amount of skill, so thank you. My question is more for Lucy. You talked about the 15% recurrence rate. I'm just interested in, is that proportionally the same with your males versus females? I know the cohort's really small, so it's probably hard to tell, but I'm interested, do you get more recurrence rate proportionally in females than males?
Lucy.
The answer to that question is watch this space, because there is a study in the pipeline. Yes.
Yes.
A question for Lucy. Could you sort of comment on when you might hit the jackpot for a SCAD? Talking about all the different environmental factors, smoking, high blood pressure, the genetic component, but where's the jackpot for the risk of SCAD?
So I think if I've understood your question correctly, it's when do you reach a threshold to develop the disease? And my feeling on this, and I'm not sure that I have really solid evidence, is it's different for everybody. So I think some people likely have a stronger genetic predetermination for developing SCAD, and they need less of the environmental sort of triggers, so to speak. And then on the other side of that, for another individual, they might not have much genetic risk, but they have a really sudden trigger, really sudden environmental stressor. And so the environment plays a bigger role. Yes, as I said, I don't have a publication to quote on that, but that's my thinking, and open to others with expertise in the group also to state there.
Yeah, I think that's a really important question. And the fact that we've got people who are monozygotic twins, that is identical twins, one of which has had SCAD and the other hasn't, says that environmental factor is very important. So the one person had an environmental factor and got SCAD, and the other hasn't yet had that. Yeah, that's a question.
Sorry. So you did mention briefly about beta blockers. Women and beta blocker usage didn't have heart damage, and looking at that, it may not be a good option. So at the moment, for your current research, you're suggesting from a SCAD patient they should stay on their beta blocker until obviously we find out more information.
So we did predict this question was coming. So at the recent European Society of Cardiology meeting, which Jason attended, there were two big beta blocker trials that were announced, and a sort of summary of those trials. So those trials were done in all comers with infarcts, so not just SCAD affected individuals. So at this point, I don't think they inform us particularly of what to do in SCAD. So, you know, we're working on the observational studies that we've got, as well as a trial, a randomized trial specifically in SCAD, which is going to be published soon from Spain, and sort of the mechanistic understanding of the disease, that it's, you know, it's a disease which seems to be contributed by wall shear stress, of which beta blockers are beneficial. I can't sort of provide like individual recommendations, but, you know, at this time, it's kind of where we're standing still. Yeah, these big studies were mostly comprised of like atherosclerotic cholesterol sort of build up coronary artery disease, infarct sufferers. So, yeah.
Yeah, they make clinical sense, although we haven't yet got definitive proof, but they certainly make sense. Unfortunately, some, especially ladies, can't tolerate them because they get the low blood pressure, and then of course, we have to really reduce the dose or not use them at all. I think we should move on. And
Great. Thank you.
Thank you.
Great. So I'll let Nicole up. So Nicole Bryce is in my lab, and she's going to talk about Practice 1. Nicole's my lab manager. Does an amazing job leading the research in the lab, and also just organising things and helping me on a day-to-day basis. So what's important about this talk is it's about the gene FRACTA1. So FRACTA1 was the first gene identified for all of the diseases that we're here today to talk about. So fibromuscular dysplasia, SCAD, cervical artery dissection for the people in the room that have had that may or may not have got FMD and so on. So for all the patients in the room, this talk is relevant. So this has been an ongoing work. So over to you, Nicole. Thank you.
Thanks. So as Jason mentioned, I'm one of the senior scientists in his lab, and here is a picture of our current team minus our honours student, Hannah. And our goal as scientists is to understand vascular diseases at multiple levels. And this means that we start from the molecules, the genes, all the way up to people and levels in between. And we want to use this knowledge in particular to design some therapeutic agents that will eventually benefit patients. But there becomes a problem, is that we find all these genes in big studies and it's like, well, what does that do? How do we know how it works? Is it a problem with the protein? Is it just too much? We don't know until we do some further study. And that's what we're doing. And so we need to understand these processes so that we can develop something, you know, imagine just a drug or something that we can give to people who've had these issues, but it has minimal side effects, and so it doesn't make you sicker. Okay. And our gene of choice that we're working on understanding is factor 1. And this is one of the top variants that was identified as having a role in both SCAD and FMD. And I want to talk to you a little bit more about what happens is, imagine Ingrid's given me the study that says, we found this top variant, what does it do? And that's what we're trying to answer in our work. So I want to take you back just to a little bit more of a scale of the problem that we have. So welcome to chromosome 6. That's where the factor gene is located. You have 2 copies of chromosome 6. You've got one from mum and one from dad. There's over 172 million base pairs, or the letters A, C, G, and T on that chromosome, of which the factor gene is almost 300,000 of them. Okay. And so it's, you know, in the grand scheme of things, it's, 0.1% of that chromosome, and it's one change that's causing these problems. Okay. And so that's in the DNA. Okay, and so that is, where's my thingy? Oh, okay. Anyway, so that is the DNA, and that then gets transcribed into something called mRNA, and that's the coding sequence that is eventually turned red and turned into a protein. Okay, so that 280,000 base pairs, only 5,500 of them are actually important to tell us what the protein structure is. But of those 5,000, only 1,700 of them are actually needed to tell the cell how to make that protein. Okay, and so I've got a nice little representation of a protein that looks like Pac-Man, which is important for the next slide. So this is what's known as the central dogma of molecular biology. DNA codes for RNA, which codes for protein, and the proteins do all the work in your cells. Okay, so if Ingrid tells me we've got a variant in the coding sequence of a gene, okay, normally we would go the DNA, the RNA, make our normal protein. In the middle example here, we have a variant that's happening in the coding region, and this means that it's important for this sequence of the protein that the gene makes. Okay, this can have 2 different effects on the protein. First, we could make an altered protein that has the wrong structure, the wrong shape, and therefore it doesn't do its job properly within the cell. Okay, and you can see we've gone from Pac-Man to his mouth is shut. Okay, this means it might not be able to bind to another protein to do its job. The other thing that might happen is it might tell the cell's machinery to stop making that protein at that point. And at that part, you have a short protein. Okay, so you might be missing an important domain at the end that is responsible for the protein's function. And so it might be just not work, okay? These, in terms of drug discovery, are relatively simple to think about designing compounds for. Now, not simple in terms of it's going to take 10 minutes and, here's your drug. It's 20 years, still going to be 20 years of work. But you only have to stop that faulty protein from working, okay? You just to restore normal function of your other copy. So that conceptually is a much easier way of designing drugs. Okay, so the thing with factor and our variant is that our variant is in actually the non-coding region. Okay, so this means that our protein sequence is exactly the same as a normal factor protein in a person that doesn't have our variant. Okay, so what this actually does though is it changes the regulation of how much RNA the cell makes from our gene. So if you have the AA variant, this means that our cells make more mRNA and therefore more protein. If you have the GG at this site, our cells actually make less RNA and we have lower amounts of protein. Okay, so functionally this variant, although it's one of it's the top thing associated with FMD and SCAD in the polygenic genes, we're actually not having a mutation in the protein. So the protein is normal, we just have different amounts of it, okay? And the reason why this becomes further complicated is that if we have too much of the protein, i.e. the AA alleles, this is when we get fibromuscular dysplasia and SCAD, and this again is associated with a higher level of factor protein, and it's predominantly women. But if we have a lower level of factor in our bodies, this is where it actually causes atherosclerosis. Okay, and this is predominantly a male disease affecting about 75% of people. So we have this balance of too much of factor, we get SCAD and FMD, too little of factor, you get coronary artery disease. And so it's this balance that's going to make drug discovery rather challenging, because we can't just say, hey, let's just block factor 1, let's not make it work anymore, because, atherosclerosis will develop. So we have to take a different approach. So we have to work out, what does factor regulate in the cells, and can we actually target a downstream effect that is disease specific? Okay, so only when we have too much factor 1 and it turns on this pathway, can we target that pathway? So that's what we're trying to understand in the lab, is what does factor actually do within the cell? So we have a number of different models in the lab that we're working on. And I just want to show you, first up, these are some pictures from the aorta of our mice. And in the yellow, this is just what a normal, a schematic representation of the cells, the endothelial cells lining your artery and the smooth muscle cells behind that. And so this is the endothelial cells in yellow that have actually been stained with an antibody that recognizes factor 1. Pardon me. And you can see that they're in the endothelial cells as they line up with this marker of endothelial cells. But we also have expression in our smooth muscle cells. So factor is definitely present in the artery. And so we have a mice that we've actually removed the whole entire 280,000 base pairs of factor 1. And we are actively looking at what happens in these mice. But today I'm going to be talking to you about a couple of other little projects where we're using the power of technology to study thousands of things at once, rather than doing individual one-on-one experiments. And so to do that, we use the cells that we've changed the levels of factor 1, and then we do multiomics. And so I just want to explain what multiomics is. First, I have made these cells. So on the left, these were all originally the same cell line. We've just used a lentivirus system to change the expression of factor 1 protein. So we've either knocked it down, so these cells have about 80% less of factor, whereas our factor 1 overexpression cells on the right, they have about 6 times as much expression. So we're going for extremes of, to try and work out what we're doing. So, and as you can see, they all originally started out the same, but we're getting very different effects on the actual, what the cells look like. Cells on the right are rather stiff. They've got these big stress fibers. In a former life, that's all I studied, was those white lines in the right hand. I spent 15 years of my life looking at those white lines. Okay. And I know you can design drugs to them because I've done it. Right? But that was in the cancer background. But so it can be done. But anyway, what we did was then Catherine, who is a senior postdoc fellow in the lab, she took these different cell lines and she extracted 4 different things. So she had 4 different experiments set up. First, she extracted the RNA. Then she extracted the proteins, then the metabolites. And the metabolites are things like if you've got glucose and it's broken down into things, that's what you're measuring. The breakdown of proteins, the breakdown of carbohydrates, the breakdown of fats, that's what she's measuring. And then lipidomics, that's the different types of lipids in your cell. And it's not just, the fat that we have stored around our body. Every cell in our body is surrounded by a fat layer, like a lipid bilayer. And that's made up of many, many different types of fats. And these change depending on the cell type and depending on changes to other proteins. And these have important roles in signaling. Okay. And as Ingrid already alluded to, the results of these computational work, it spits out all these numbers. It doesn't look particularly pretty. And you end up with a whole heap of these plots called volcano plots. And all it means is the red dots means this gene, this protein, this metabolite, this lipid went up, or the blue, it went down. And the gray means it didn't really change. Okay, and so we are able, using these techniques, to measure in a population of cells at one time up to 19,000 genes all at once, right? 10,000 proteins, 5,000 metabolites, 10,000 lipids. And so individually, just these experiments on their own provide us some really valuable information about what's changing when we change factor levels within our cells. Catherine, however, took it one step further. She then decided to combine all of those 4 data sets to see, can we actually link up the changes in the genes to the changes in the proteins, and can we, see if that matches up to the metabolites or the changes in lipids, right? This is asking, can we find a biomarker that, relates back to factor changes in the cells? And so this was a whole heap of computational work done by Catherine and Angela, who's in Jason's lab over in New York. And it really started to pull out some networks that factor is working with. And I must ask, please don't take a photo of the next slide because the paper is this close to being accepted. And we don't really want to foreshadow it online. So because this is actual real research data that will come out very soon, we'll let you all know. But Catherine has found some really interesting pathways that factor is regulating. And so these relate to vascular function. And so this is where Santhi was talking about, the collagens and all the proteins that form up the structures. We do see that factor is regulating some of these pathways. Energy production in terms of your mitochondria. You've probably all heard that, the mitochondria is the powerhouse of the cell. Well, that everyone says that's all I remember from biology. That is actually really quite important in maintaining the health of our cells. And factor is having a significant impact on energy production within our cells. And also iron signaling, which, may be important in terms of the whole female-male sex distribution thing, because the females just obviously we have, vast changes in our iron levels, every month for quite a while. But, so we are looking at these key pathways that Catherine has identified. And I must say, this is the first study in the world that has been able to link all of these 4 data sets together. Previously, you could link 2, maybe 3, but she's managed to get all 4 of them linked, and it was a massive piece of work. But now that we have all these pathways, how do we know that they're disease specific? And so to do that, Carmen Mifsud in our group, who is our new PhD student, she's going to be using stem cells. And stem cells are cells that we can turn into any different type of cell in the human body. Okay, we are, the ones that we have, they've been extracted from someone's skin and they've been converted into stem cells. And we can turn those into endothelial cells that, that line your blood vessels or the smooth muscle cells. So what we've done is we've gotten a male cell line and a female cell line, and we have introduced the single change. First of all, we sequenced them to work out what they were, thanks to Siri. And so we worked out if they were AA, AG, or GG at the specific factor variant. And then we used CRISPR gene modification up here in the Innovation Centre at the Victor Chang, and we changed the copy to what we wanted. So we will have 3 cell lines, 3 men, 3 women, that we've got AA, AG, and GG. So the only thing that will change is that one variant in factor, and then we plan and go on doing all the omics experiments again, just with this one change. Okay, so we will throw in one more just because we can, which is ATAC-seq, which is to look at chromosome structure. And we hope that we're going to be able to identify cell-specific pathways, because we will turn these cells into endothelial cells or smooth muscle cells, both factors in both sorts. But we want to find a druggable pathway that is specific to the AA variant. Okay, so we won't be targeting factor itself. We'll be finding the pathway that factor regulates in an AA variant specific manner. And hopefully this will allow us to design some molecular targets for drug discovery. And with that, I hope today that I've shown you that we are working on these diseases at multiple different levels. We've got many different projects happening. I only had 15 minutes. I couldn't talk to you about all the exciting things that we're doing, but we do have 2 posters on our mouse work and our collagen work out in the hall. And using these powerful multi-omics studies that we can do thousands of things at once instead of doing one thing at a time, it really accelerates the research and allows us to link different pathways that we might not have thought were useful or even related into what's happening when we have this variant. And as I said, we're going to use these stem cells to really narrow it down to a cell type, pathway type. And as again, our overall goal is to develop a therapeutic to help SCAD and FMD patients. And so with that, I'd like to thank everybody involved in the research.
So we're a bit over time. The next talk, Barbara, is quite different to those on psychosocial aspects. So we might just move a couple of quick questions for Nicole. We'll move to Barbara.
If not, I'll be at the posters.
Check it out. You want to speak? No question. So
Yeah, no question.
Yeah. Sure.
When you tweak the genes in the lab and the proteins and so on, is there any direct correlation you can find between what you're doing and environmental factors and any other factors?
Not yet, but we have our mice for that.
Okay.
So
You're looking for that in the mice?
Not just yet. That requires a 30-page application to the ethics committee. But if there is something that comes up, we can have the models to test it.
Excellent.
Yeah.
So it's a pleasure to welcome Barbara Murphy. Barbara comes from Melbourne. She's a senior fellow from the School of Psychological Science at the University of Melbourne, associate director of the Australian Centre for Heart Health, and a close collaborator. She has a 30-year history in psychological research. So she's going to be talking to us about psychological recovery after stroke. But I would say, Barbara, that I think a lot of what you're going to speak about also relates to people who might have had a carotid dissection or a vertebral dissection or other dissections. So it is relevant to, I think, a lot of people. Thank you very much.
Thanks so much, Jason. Yeah, a little bit of a change of pace here to move on to talking about the psychological side of SCAD. And in keeping with the day, I am trying to look at differences between people who have had SCAD without FMD and those who have had SCAD with FMD. So I've had a look at our data specifically for today, just to, whoops, not sure how I'm moving my slides along. How's everyone been going?
On your laptops.
Yeah, that's not coming up. I don't know what's happening. I just can't get it to move along.
Oh, yes.
It's not coming might need some tech help. It's not working. It's done it. Oh, good. I don't know what I did. Okay, working. Thank you. Problem diverted. Yeah, just firstly to acknowledge the teams. Obviously, our team at the Australian Centre for Heart Health has been working really closely with the wonderful team here at Dr Chang. Also our patient advocates, including Sarah Ford up the back from SCAD Research Inc. and others at Uni of Sydney. So a really big team. We've been working together on this work for about 4 or 5 years now. So we know that SCAD occurs out of the blue. It's traumatic for a number of features. It occurs out of the blue. Management's difficult, different to usual heart attack, can be triggered by physical exertion, and that can make it tricky with management as well. Relatively rare and at relatively high recurrence rate compared to normal atherosclerotic heart attack. And this makes people feel a whole range of emotional impacts. There's shock, there's uncertainty about management and exercise, feeling isolated and alone because it's rare, and worry about whether it'll happen again. So we sought to undertake a series of projects with between the ACHH and the Victor Chang group. We did a number of focus groups with people who'd had SCAD, online focus groups back in 2023. Some of you may have been involved in those. And then from there developed up a questionnaire that we put out on an online survey, and I'm going to report on that. And then from what we found, we developed up an online SCAD support program, which Lucy referred to earlier. So all these studies have been in collaboration. So our focus group work, we talked to 30 people who'd had SCAD. We just had 3 men, all the rest were women, across 7 focus groups that we did online. They were very confronting because everyone, as you will all know, expressed the range of emotional impacts that their SCAD had had on them and their lives and their emotions. So they talked about uncertainty, grief, loss, confusion, sadness, disappointment, frustration, feeling alone, all these sorts of things. So from there, we developed up a questionnaire that we then put into our online survey. And that questionnaire had 48 items in it that addressed each of these things that we'd found in our focus group. So this is just a little snip of it. So we asked in our questionnaire and our big survey, during the first 6 months after your SCAD, to what extent did you experience the following? And we had 48 items there. I've just shown the first 7, and people responded on this scale. And I'm going to show you some of the results of those. So when we put the survey out online, and again, thanks to Sarah Ford with helping with recruitment here, otherwise most of the people are through the database here at the Victor Chang Cardiac Registry, so genetics registry. So some of you may have actually done this survey. What I want to show you today is the comparison in some of the responses on these questions for those who did have FMD versus those who didn't. Now, in our survey, we only had 53 of the 310 people who responded who ticked the box to say that they actually did have FMD. We know that that's an underestimation. As we've heard today, it can be up to about 50%. I think Jason mentioned, Siri found for me another article the other day that had 41% of people having FMD if they've had SCAD. So we know our 17% is a little bit low, and it might be because some of the people who did the survey either didn't know whether they had FMD or not, or didn't indicate it, but just keeping that in mind. But nonetheless, I'm going to compare the 53 who had FMD with the ones who didn't in response to some of those items that we had, just to show you the demographic characteristics. So in each of the slides I'm going to show, I've got the proportion across the bottom, and the bars show the FMD people in the red and the non-FMD people in the blue, and then I've got each of the items up the side there. So you can see most of our sample were women. In fact, in our FMD group, we only had 1 male out of the 53. Mostly employed, mostly partnered, about half and half under 55 and over 55. So 55 was about our midway point, and a bit of financial strain, around 30%, which is a little higher than what we see in the general population. Now looking at our SCAD items, I'm going to report on the proportion of people who said they experienced this thing in the first 6 months after their SCAD to either a moderate or large amount. I should have highlighted on the previous slide, the time since SCAD did range for a long time. So we had people who were up to 18 years after their SCAD, a mean of about 5 years. We only had about 10-15% who were in the last year. So it's people who've had their SCAD sometime in the past. So just think on average 5 years. So I'm going to talk to those ones. I'm going to show you these across 4 different domains. So the items across the 48 questions that we asked fall into 4 main categories. Challenges to sense of identity, fear of recurrence of your SCAD, concerns about reduced capacity, and lack of support and validation. So I'm going to go through each of these in turn and compare the proportions for the ones who did and didn't have FMD. So starting with the domain about challenges to sense of self. So go from the bottom, because that's the highest one. Shock about having had a SCAD. You can see that nearly 85% of people have indicated that they were shocked at the time they had their SCAD. Now, shock is very concerning because it can be a precipitator for PTSD, post-traumatic stress disorder. So it's not just shock, oh my God, I'm shocked. This can be a deep-seated shock that can really rattle and unsettle a person. So fairly high ratings there. Worry about the impact on family members, about 70% there. Then going down a little bit, loss of self-confidence, sadness, feeling your body's let you down, and the fear of dying, over 50%, nearly 60% there. That's a fear in the first 6 months, and feeling vulnerable. In this set of items, no differences on a statistically significant level between the FMDs and the non-FMD group. So these were all, even though you see some little variations there, none of them are what we call statistically significant when we compare them statistically. Second domain, looking at fear of SCAD recurrence. So again, starting at the bottom, over 80% indicating worry about having another SCAD or concerns about triggering their SCAD. Also confusion about safe levels of activity and exertion. I can see that this can be quite an upsetting topic for people to watch all these things, and we really do understand this. These are really common experiences that people have after SCAD or an FMD diagnosis. So yeah, if it's triggering you, I really am sorry, but I hope that you're okay. So you can see that confusion and then fear about the future and uncertainty about managing your condition. So these concerns about physical activity and management are all related to concerns about triggering another SCAD event. Okay, so this one's a really high domain. When we look at the differences, it's the FMD people, you can see a little bit higher on the bottom 3 domains there and statistically significant for the FMD group on confusion about that activity and exertion there. The other differences aren't statistically significant, but a bit of a pattern there of higher ratings for the FMD group. This one's very busy, but again, let's start at the bottom. You can see now for this one, concerns about reduced capacity. The ratings have gone down a little bit, not as high as the fear of recurrence ones, but you can see loss of previous lifestyle, over 60 to 70%, issues around fatigue and tiredness, restrictions on physical activity, all around 50 to 60, sadness about things you can't do anymore, concern about being a burden on others, about 50%, exhaustion with family responsibilities, worry about finances and work. You can see they're going down a little bit, but still around 40% there, and then loss of independence and relying on others. So those concerns at around 30%. And in this one, you can see pretty strong pattern where we're getting slightly higher rates, statistically significant, for the FMD group. So on several of those items there where we've got the arrows. And finally, our last one, again, there's a lot of them here on this slide, but just working from the bottom, concerns about side effects of medications. The medication issue is quite a strong one, and we've seen that come up today about should I or shouldn't I be on these medications. So worry about that for about 60% of people. Feeling health professionals don't understand and feeling misunderstood, around 50 to 60%. Conflicting health advice and confusion around that. getting down to sort of 40 and then 30% feeling abandoned by the health system, isolation and loneliness around 30%, anxiety about the care you're receiving. This is all to do with health professionals' uncertainty about managing the SCAD and the learning curve that health professionals are on themselves around SCAD, particularly if they're working in more isolated areas and haven't got the familiarity with it. Confusion about medications, again, as I've said, that's come up a bit today. Only about 20% in our study indicating that one. And feeling unsupported by family and friends, pretty low rating there, so mostly people having pretty good support. Again, we're getting a higher rating of endorsement across for our FMD people here across a number of those. Impacts on lifestyle, we did ask in this survey as well, and the first three there relate to working. So 20% had stopped working due to their SCAD, many had reduced their hours up to 50%, and around 30% had changed jobs. Small proportion having sought financial help because of their SCAD. I think this one's concerning. Nearly 50% of people have stopped doing a favourite sport or activity. Again, that's to do with the fears of recurrence and so on. A small proportion reconsidered pregnancy. And you can see just one of those statistically significant, but a little pattern there for the FMDs to be, again, a little bit higher. We did also ask about perceived triggers. And again, this has come up a fair bit today. In our survey, 60% of people said they believe that emotional stress in the days leading up to their SCAD had contributed. Smaller proportions for strenuous exercise on the day of SCAD, and significantly more so in the non-FMD people than in the FMD, and concerns about childbirth and pregnancy. No one in our FMD group who indicated that. So that might be just due to our small sample there. So we can see here that what we've learned is that the greatest concerns on all of the endorsement across the items really relate to fear of SCAD recurrence in our sample here. And that those with FMD do have higher distress across some of our items, particularly relating to concerns about reduced capacity and lack of support from the health system. They were the third and fourth domains. But we've got to be cautious about these results for the comparison due to the small numbers of FMD we had in our sample. And also, in our sample, there was a higher proportion of recurrent SCADs in our people with FMD, 34% versus 20% in those without. So these effects might actually be due to having had a second SCAD rather than the FMD per se, and we haven't untangled that at this stage. Now, obviously, our studies showed that there's a lot of emotional impacts of SCAD, and we were able to quantify that. We've published all this data. It's gone into the international sort of conversation around how to support SCAD survivors in the aftermath of their SCAD. So we did develop an online support program, and I just want to talk to you a little bit about that to end on a slightly more positive note around what we're doing to help support you all in your recovery after SCAD. We asked people in the focus groups what did they want in terms of support. They said they wanted both peer and professional support, hearing stories from other people, getting connected with other people, but also having guidance from properly trained psychologists. So we developed up a 4-session online group program, and that was co-facilitated by a health psychologist and some of our wonderful patient advocates who had had a SCAD themselves. And we pilot tested this with 33 SCAD survivors here from the Victor Chang group, again with the wonderful help from Stephanie. We did 4 women-only programs, each of 4 sessions, and 1 male-only program, which was 4 sessions. And the men in particular loved being in their own program because many of them hadn't had an opportunity to even meet another male who'd had SCAD. I won't go into this in great detail, but the programs are based on the psychological theory of acceptance and commitment theory, which helps to identify and understand these emotions, process them in a supportive environment, and align choices and behaviours and lifestyle with your own personal values. And it's really appropriate for SCAD, where there is this high uncertainty and these high emotional impacts. In the 4-session program, this looks busy, but basically all of the sessions followed the same format. The first one, you obviously get to know the group, but then share your emotional experiences, and you do it in the context of this ACT for SCAD model, which is the circle there. Then you talk in the next session about values, purpose and passion, linking that to your life, again, using this model. Then you look at roles and relationships in the third one, and then managing uncertainty in the fourth one. And common to all the sessions is sharing, group discussion, normalising and validating, emotional support from the facilitators, and then using this theory-based, evidence-based model. We had people talk about both how useful it was to be able to share their emotions, name them, understand them, realise that they were common to pretty much everyone, nearly everyone going through the same thing, but also how important it was to connect with other people, and also how important it was to have the psychologist work through those emotions with them. We did measure a whole range of psychological constructs before and after in these 33 people. We found that anxiety, depression and distress all reduced between before and after doing the program, and life fulfillment, confidence and enrichment in life all increased, all statistically significant. And again, we've published this data. Funding permitting, we would like to continue to deliver this program, potentially through the Victor Chang Institute, and we're looking for funding in order to make that happen. I'm currently working with similar psychologists in the UK, the US and Canada to make sure all our support programs are integrated, connected and internationally relevant. So we're all working together on this. And I'm also collaborating, and several of us here at Victor Chang Research Institute collaborating on looking at guidelines for exercise after SCAD, which will help to reduce some of that uncertainty and confusion. And another study looking at specific issues for pregnancy-related SCAD that we're starting on next year. And, you know, thank you to all of you for being here today and for being involved in all our studies, because it's through everyone's involvement that we're able to learn and understand about this really important side of the emotional impacts of SCAD. Thank you.
Case of one, I haven't had a SCAD. I have FMD, and this is the first time I've seen any coverage of anything like what for me has been, I think, the most profound part of my experience, like a social thing. How might, this is a SCAD online support group, how might someone with neuro experience, not cardiac experience, access information, access this sort of support or ongoing groups? I would love to be involved in a group like this. I don't know how best to do that.
Yeah. Well, currently we're not running this particular program, but we definitely want to, and Siri and I are working actively to try and make that happen through the Victor Chang group. This program was developed more for those who'd had a SCAD event, but I think we could modify it so that the emotional impacts are almost identical, whether it's FMD or SCAD in the context of FMD or vice versa. So I think it doesn't really matter, in that the program would be, I think, suitable for everyone. So hopefully we can get something running, and it's really important that you have to ask that question, because I think we'll have to make sure that it's tailored to people with FMD who haven't had SCAD as well.
I think it's about neck dissection though specifically, right? Is it?
Yes.
We can chat.
I had a SCAD 7 years ago, and I was referred to cardiac rehab, and it was the most valuable thing for me 3 sessions of 7 weeks, 3 times a week. But I was their only SCAD patient. They never had a SCAD patient before. They knew nothing about it.
Yeah.
Is there any way information can be communicated to all the cardiac rehab units around the country to alert them to particular needs of SCAD patients? The exercise physiologist hadn't heard of it, didn't know about it. So I ended up sort of educating them a bit,
Yeah.
as well as rehabilitating, going through the process, which was incredibly helpful because it was a safe environment. But it would be wonderful to think that all the cardiac rehab programs, which are wonderful, could have more information or some information about SCAD.
I think that's a really, really important question. There's about 350 cardiac rehab programs across Australia. Many of them haven't had a SCAD patient. We know of a sprinkling of them where they're really attuned to SCAD. We've got one down at Caulfield Hospital. There's one in Adelaide that I know of. There's the Westmead here, and probably St Vincent's as well, really attuned to SCAD. Sarah's going to add to this too. I've been doing webinars for the Australian Cardiovascular Rehab Association where I'm talking about this. So I'm working hard to educate people. And so in the process from 7 years ago to now, I think there's a lot more info, but I repeatedly hear people tell me that they had to tell the cardiac rehab people what SCAD was. Sarah, did you want to add?
Yeah, we've been doing, so I'm Sarah Ford from SCAD Research Inc. Australia. We're a volunteer-led, survivor-led charity. We raise money for the amazing work of Dr Chang. We support studies across Australia. We support survivors. We've got a big fundraiser next weekend. We've been working with ACRA as well as Murphy. And also there's now some online rehab programs that are developing SCAD specific. So just SCAD survivors are in those groups. And there's also some postdoctorate work being done on some video cardiac rehab programs for people. So there's a huge amount in this space. And I think we're really hopeful that in the next 6 months, 2 years, there will be dedicated cardiac rehab programs online, in person, major cities, remotely, which are dedicated to SCAD and the specific, stop talking to me about not eating hamburgers and smoking, talk to me about what I need to do in terms of my condition. And that's some of the amazing work that you've been doing. So there's a lot of interest in this space, and I'm really confident in the progress that's being made. And in the meantime, you can actually go to our website and download SCAD-specific guidelines for cardiac rehab, and we have that as a resource for people to take to their cardiac rehab. So we've had hundreds of people say, my hospital has had one person in 10 years. I took them this brochure and now they know. I can't do isometric exercises. I can't do, the whole list of what they can and can't do for SCAD. So in the meantime, please go to scadresearch.com.au. It is a gap fill while all of this amazing work is happening, because we know that information is power. We know that when people feel supported and they know there are dedicated programs and they can provide specific information, it's really empowering and it gives you lots of confidence, but also it means you're not being lectured about smoking. You've been given SCAD specific information. So just to build on that work that you're doing, and I have so much hope in this area, like where we've come from. Cardiac rehab is really leaps and bounds.
Thank you.
I'm a bit of an imposter. I didn't realise this was just for patients. I run a cardiac rehab out at Nepean Hospital. We're getting SCAD patients back to back. Like one will finish, one will start, be a bit of a overlap. So I think it's being more recognised now. And we are waiting for some official guidelines of how hard we can maximally test patients and stuff like that. But not getting the volume to run a standalone program, but we definitely have altered our education sessions to include SCAD as one of the types of heart attack, so we're not very heavy on those traditional risk factors.
Thank you.
I'm conscious we've been in the room for 2.5 hours, so one or two last questions, but we can continue all the conversations outside, and the whole team will be out there to answer questions to keep you individually for a while. Any final questions, or should we wrap it here? So, okay, I do want to really call out Stephanie. Stephanie, stand up, please. She's walking around, she's organising the tea and coffee for us. So thanks to them. Thank you all for coming. And just to touch on what Barbara said again, if you know, some of this is probably a bit confronting for some people. You're hearing about all sorts of things. So, you know, speak to us, speak to friends, family, other patients, and so on. We're here to help. Anything we can do on your journey is that's our career. That's what we do. And so we're here to help. Thanks again for coming, and look forward to chatting with you all outside over tea and coffee. Okay.
Yeah.